Hi everyone, my name is Aubrey and I am a current PA who's also a DMSC candidate here at Wingate University. Today I'll be presenting my clinical review on the use of olanzapine in chemo-induced nausea and vomiting, which I'll also refer as CINV. To begin, let's talk about the scale of this problem, okay? So cancer has a significant global impact. In 2022 alone, there were nearly 20 million new cancer cases and 9.7 million deaths worldwide. It is estimated that about 70 to 80% of these patients are at risk of developing nausea and vomiting, and this can not only affect their quality of life, but can also impact their willingness to continue life-saving treatment. While standard antiemetics are available, many patients still experience CINV, particularly when they're on highly emetogenic chemotherapy. So personally, as someone who works in hemonc, I do see many of my patients get nausea and vomiting. So when we do our chemo education visits, we also make sure that they know about nausea is a side effect, and we kind of talk them through how to manage that. And highly emetogenic, what I've seen, kind of those higher risk one, like Taxol-based, platinum-based, those kind of regimens can increase the risk of patients getting nausea. So what causes CINV? Well, the vomiting reflex is quite complex, and it is a process that is managed by the vomiting center in the brain's medulla oblongata. In this center, it's going to respond to signals from both the central nervous system and the intestinal tract. Key neurotransmitters that are crucial to this process include serotonin, 5-HT, dopamine like the D2, histamine, H1, acetylcholine, M1, and neurokinin 1 or NK1. So when chemotherapy damages the gastrointestinal tract, these neurotransmitters are going to be released, and when they're released, they're going to send signals that are going to activate the vomiting center. And this ultimately can lead to symptoms like the nausea, like the increased salivation, and the vomiting. So just as a background, there are a couple different types of CINV. There's the acute, which occurs within 24 hours of chemotherapies. This is primarily mediated by serotonin, and oftentimes we actually pre-medicate patients before they get their chemo with, Zofran, which kind of hits that 5-HT3. Delayed can occur 24 hours to 5 days after, and this is mainly mediated by substance P that binds to the NK1 receptors. And there's also anticipatory, where people feel like they're going to get nausea before the chemo regimen even begins. And for those cases, we actually do have a nausea regimen where people stay on. So they might take like olanzapine or a Decadron the day before, and then a few days after their chemotherapy. So moving on to olanzapine, it is a second-generation antipsychotic, and it has actually been proven to be very effective as an add-on therapy because of its ability to block multiple neurotransmitter receptors involved in the vomiting pathway. And its efficacy is quite well documented. So ASCO, or the American Society of Clinical Oncology, actually recommends including olanzapine in antiemetic regimens for patients receiving highly emetogenic chemotherapy. Again, I've seen this when they take it the day before and then they take it the night after chemo and the second night after chemo. Another major clinical trial published in the New England Journal of Medicine found that adding olanzapine to a standard 3-drug antiemetic regimen was significantly more effective than a placebo in preventing both acute and delayed CINV. Again, something I've actually seen. If the Zofran compazine is not cutting it, then adding on olanzapine actually does seem to help. And just to put the nail in the coffin there, in fact, a meta-analysis actually has estimated that using olanzapine can double the likelihood of a patient experiencing no nausea or vomiting at all. So olanzapine is a powerful tool for managing breakthrough CINV, and it affects about a third of patients even with preventative therapy. One study has also demonstrated that olanzapine is used as a rescue medication, was highly effective, and achieved overall remission in about 83% of patients. And it's important to note with any medication, there is going to be side effects. So the most common one with olanzapine is going to be sedation or drowsiness. And while it can be kind of concerning, it may be beneficial for those patients who are also dealing with anxiety or insomnia. And other lesser reported effects include dizziness or dry mouth. Now, olanzapine has a long half-life of about 21 to 54 hours, And there's research going into that they have found for CINV prevention, the 5 milligram dose has actually been found to be just as effective as a 10 milligram dose, but with less risk of drowsiness, and even lower doses of that 2.5 milligram have been shown to also be effective for managing nausea symptoms. So, in conclusion, olanzapine is a valuable and effective agent for the primary prevention of CINV when used in combo therapy. It has a unique ability to block multiple neurotransmitter pathways, and it makes it a powerful tool in our arsenal against nausea and vomiting. And while sedation is a primary concern, this can often be managed with dose adjustments. Now, with any research, there's always more that can be done and studied. So, looking into olanzapine's role in managing breakthrough CINV as a secondary prevention method, its potential use as a single agent for nausea in palliative or hospice care settings, the efficacy and safety profile of olanzapine in pediatric patients, and finally, looking at its long-term safety profile. So below you'll find my references, and thank you for your time. If you have any other questions or concerns, just let me know and comment below. Thank you.